Joint Commission International lists over 1,000 organizations globally. The purpose of those standards is uniformity.
Hi, my name is Kumar Dharmarajan. I'm co-founder and chief medical officer of World Class Health. Today we have with us Dr. Stephen Matarelli. Stephen has decades of experience working with global centers of excellence. He's currently at Medpoint Health Partners, and formerly he was chief clinical officer and chief operating officer at Johns Hopkins International. He was a field supervisor at Joint Commission International, a leader at Vocera Communications, representing the voice of the patient, and many other things over the years. Stephen, welcome.
Thanks very much, Kumar, for the invitation.
We're really happy to have you. So let us start at the beginning. What led you to focus on global healthcare?
It's a great question. So I've been a registered nurse for 39 years. And up until 2006, all my experience was US-based, both my clinical and my executive experience. In 2006, I had an extraordinary opportunity to join a brand new project with Johns Hopkins International. And this was a C-suite position in the United Arab Emirates at a tertiary teaching hospital. It was the first for Hopkins International. It certainly was the first for me. I was there 7 unbelievable years. And I think the amazing thing about it was not only the cultural diversity of our patients, but it was the cultural diversity of the staff. We had staff from over 70 different countries. And although when I looked at my 1,300 nurses, many of those 1,300 nurses were educated as nurses differently than the way I was educated. Not wrongly, just differently. So one of my personal challenges, and one of the challenges of the organization and Hopkins International in its entirety, was to bring that uniformity of care into tertiary, high-class, world-class standards that at the time carried the branding of Johns Hopkins medicine. So it was an extraordinary time, and I've never looked back. Once I got the taste of global healthcare, I've continued to that to this day.
I think that's an amazing point around care may sometimes be different, but it needs to be, appropriate, culturally appropriate.
Absolutely.
Needs to meet certain uniform standards, but there is some variation that is appropriate for the country. As you moved from Johns Hopkins, I know you spent time at Joint Commission International, where you, I think, got to survey hospitals across many, many countries. You can tell us about that experience. Maybe start by explaining what led you to Joint Commission International, and what is Joint Commission International for our audience?
Certainly. So Joint Commission International is actually an extension of the Joint Commission that everyone in the United States maybe loves or loves to hate, right? And it's quite a lengthy established organization. So JCI is coming up on a 24th year, I believe, its 8th accreditation cycle. And we know this by their accreditation manuals, which are produced every 3 years. So it really emerged from the U.S.-based Joint Commission, really to meet a need. There were international hospitals that wanted to be like an American hospital. And how do you do that? How do you raise the elevation of the standards of your care? Well, you raise those by adopting a foundation of standards, a foundation of quality, a foundation of patient safety. So these standards in the Joint Commission Manual, there's 13 standards divided into patient-centered standards and healthcare organization standards. For hospitals that meet the criteria of academic medical center, there are an additional 2 chapters that add into that. So to me, it really serves as a foundation, and that's what those organizations were seeking is, can we compare ourselves to the best? Despite the challenges of U.S. healthcare, it continues to be a gold standard that many places in the world seek to achieve.
With that framing of trying to compare to the U.S. best, you've been to many hospitals that have sought Joint Commission International accreditation over the years. Are there hospitals that can meet or exceed U.S. standards based on your experience, JCI's experience?
Absolutely. So in my time with Joint Commission, about 3.5 years with Joint Commission, I participated in over 100 accreditation surveys. So that took a lot of activities. I did a little bit of research before in preparation for our interview today, and currently Joint Commission International lists over 1,000 organizations globally that have some sort of accreditation or certification. So like the US, there's a hospital accreditation and program-specific accreditation that exists in the international market as well. And those, again, according to the Joint Commission website, that's representing over 100 countries. I myself have been in some of the poorest countries in the world, and they have a Joint Commission accredited hospital. I've also been in some of the most affluent countries in the world, and they also have Joint Commission accredited. And I think the amazing thing about that standard, and by the way, there's other standards beyond the Joint Commission, but the purpose of those standards is uniformity. So I know that when I am in Bangladesh and I am in Germany or Spain or Brazil, when a healthcare person approaches me and does patient identification, the number one international patient safety goal, that it's being done uniformly, that each of those caregivers, even if we have a language different, each of those caregivers are approaching it uniformly for my patient safety.
Got it. And so if I was a patient, if I were to be a patient or an employer, there's safety. And you mentioned, there's more than 10 categories that you were talking about. How should I view Joint Commission International Accreditation? Does it mean that it's a safe hospital? Does it mean that there's, to your point, a uniformity on quality standards? Help translate to me from both a patient perspective and an employer perspective what I should take from that accreditation.
Absolutely. I really liken this to it's really a brand standard, right? A hospital or a program that's accredited with the Joint Commission and the other accrediting agencies have a gold seal. They have some sort of a moniker that can be widely displayed. It can be advertised because this is that message. This is that message to the consumer. It's really no different than the loyalty programs we see in airplanes, hotels. Your favorite department store now has a loyalty program. Your favorite credit card has a loyalty program. So what do these programs do, right? They really establish for us a foundation. So if I was an employer or an HR benefits person and I was having this conversation with leadership of the board, thinking about access to global health care, I have to measure that, right? Because there is certain variability. So when we look at how do we reduce variability? How do we make something safer? How do we make something more reliable? I spend a lot of my life on an airplane. I want to know that those pilots and those flight attendants and those mechanics and the person that fueled the plane did everything exactly according to standard. So when we look at high reliable organizations, we want to do one of two things, right? We want to reduce waste, right? That's the lean concept. We also want to decrease variability or eliminate variability. So when you look at something like the Joint Commission and you see that brand seal, you know that this is an organization who has been assessed. They've prepared, sometimes for years they've prepared, and they have been assessed by international experts in quality to those brand standards. Now, that doesn't mean the standard is identical, right? Different organizations do things, approach them differently. Some of it's related to the money that organization has, but Joint Commission steps back. The surveyor steps back from that and lets each organization organically present how they meet the standard and how they meet the measurable element. So if I was a consumer, if I was the director of HR or the CEO or even the head of a board that says, let's think about this idea of sending people abroad for healthcare, I would need to have some sort of comfort that there is some sort of uniformity, that this is an organization that is reputable. This is an organization that is reputable with peers across multiple countries. And to me, that was always my mission when I worked for the Joint Commission. That's always been my mission when I worked for organizations who achieved Joint Commission. And most recently, I rolled off of a Medpoint Health Partners project in China, where that organization was built in conjunction with advice from a highly reputable U.S. Academic medical centers. In the aspects of Joint Commission, every policy we generated was in the eyes of a Joint Commission policy. Every way the building operated, the infrastructure, how the generators worked, how the operating rooms were set up, everything was focused on how this meets and exceeds the standard of how it would be assessed from a Joint Commission perspective.
That's really, really helpful. And those concrete examples about the generators, it's not necessarily something that would come top of mind to me. So you mentioned patient safety, right, as one of the key areas of focus. But there are others. For our audience and for me as well, could you help me understand some of those other areas beyond safety that are a focus of Joint Commission standards and evaluation?
Sure. Something very simple, and I alluded to this when I talked about the 70 different nationalities, is staff qualification. How do we assess when someone comes up and says, I'm a physician and I trained in this country, I'm a nurse and I trained in that country? That could be very different. I had nurses in the Middle East and have encountered nurses around the world who really don't know how to use a stethoscope. Why? Because in their country, that's a doctor's job. I've had nurses who don't know how to start an IV. Why? Because in their country, that was the doctor's job. So one of the important things with that and with the Joint Commission standard was you bring that forward. How are staff educated? How are licenses evaluated? How do we put a uniformity of education? Because we need to ensure that the person who's caring for the patient certainly has the skill and the aptitude to be doing what they're doing. So that's one example. Another example is really the built environment. When you look at things such as rehabilitation, I've been in hospitals where rehabilitation was on the 7th floor of the hospital and took, 4 different elevators. And you step back and you go, really? Was that really the best thing for a patient who's here for rehabilitation? So you start to get, when you walk in, I had a challenge when I was a Joint Commission surveyor because my face is very expressive. So I would walk in and I would see things that I knew I was going to look at later in the survey week, but I knew it really checked the box right then, because to me, that was an organization that looked at the patient and said, well, a patient needing rehab is a patient needing rehab. It should not be difficult to access rehab, right? It should not be difficult to get from the operating room to the ICU. It should not be difficult to get from a labor and delivery suite to a newborn nursery. And when you see organizations that have incorporated engineering difficulties, that's not an organization that's quite ready to, or is not really fully embraced this concept of not only safer patient care, but a better patient experience.
And how do you think about clinical protocols? So you talked about like the physical plant makes a lot of sense. You talked about safety. You talked about education, consistency, licensure. Those are all critically important. When you think about clinical care, let's say someone's having an orthopedic surgery, or maybe they're receiving care for cancer, one form or another. How does Joint Commission evaluate quality of clinical protocols and sort of clinical systems of care?
Right. That's certainly an important thing. Organizations are expected to monitor themselves, right? So every organization, again, not just from Joint Commission, but the other international accrediting agencies, they do have standards related to an integrated quality program, all levels of the organization, not just physician, not just nurses, right? It's really this integrated structure. We look at evidence-based practice, right? It is 2024. We have on our hand, we have one of the most powerful things that we know, right? And it's this supercomputer, right? So it's how to access this. Those evidence-based protocols come from international standards. People way smarter than me, right? So, they've created, they've studied, they've researched there. I think the important thing is that there are folks around the world that actually have done this better than the United States, right? We often think, and often the United States, does have best in class, first in class. I mean, we have preeminent organizations. but there's hospitals and universities around the world that meet and exceed that as well. And sometimes that's really not known. But when we get into the professional literature, it is known. So when we start to use these clinical protocols, these clinical guidelines, not only is it a safety issue, right? It's that uniformity. In the old days, I've given a medication, hand up, medication error, because the doctor wrote the wrong medication. And I had the attitude, because that's what the approach was at the time, that I didn't question the physician. Now I would question every order I see, right? Because now I know it's my responsibility as a registered nurse to be part of that team, right? So those protocols help to reduce, again, that variability. We've got an evidence-based document that we can go back to say, and it gives me the opportunity. So Dr. Kumar, you told me, that you work in the world of geriatrics. If I were to see you write an order for, 40 milligrams of morphine, for example, my hand has to go up and I come to you professionally, but say, where did you come up with this? How did you come up with this? And why do you think this is safe for this patient? So I think that is not universal. It's not universal around the world. We still have some challenges just kind of based on social hierarchy and things. But the Joint Commission and these international accreditation programs start to permit the conversation to happen. I had examples in the Middle East and in other hospitals that I worked at that without Joint Commission standard, those nurses would never have had the freedom to question a physician, ever, because the hierarchy outside of a Joint Commission accredited, even in the same country, does not permit that type of collegial conversation. But the adoption of Joint Commission or other standards gave that permission where everybody was responsible.
That's a terrific example. And for our audience, about the 40 milligrams of morphine, one of the rules really of prescribing medications in older adults is start low, go slow, and you don't want to overdose anybody, but older adults may be particularly vulnerable to high doses of medication. But that's a terrific example, Stephen. And I think you're really, when I hear everything you're saying about the physical plan, licensure, clinical protocols, empowering nurses to speak up where clinically appropriate, I'm simplifying here, but I feel like part of what Joint Commission International does, the philosophy is that quality is everyone's responsibility.
Absolutely.
Everything contributes to quality, from the management apparatus to the commitment to quality, to clinical standards, to protocols, physical layout, the training of people, the empowerment of staff. I'm missing things, I'm sure, but it all comes together in a high-performing organization. And when the ingredients are in place, one really has then the opportunity to deliver a high-quality care on a repeatable, reliable basis. Is that a fair way to think about this?
Absolutely. It is. It is the foundation of my personal belief and of every organization who is embarked on the challenge. There are hospitals that don't pass their first assessment. We never use the term fail, right? Because we know they've worked hard, but they may have not passed that first assessment. And that means then there's a subsequent assessment, right? And it gives them the opportunity to focus. Organizations that had the understanding, one of my favorite questions of the nurse surveyor is, what's the name of your housekeeper? If the staff had no idea the name of their housekeeper, that set up for me an understanding, potentially a little biased, but it gave me a foundation to say, is this housekeeper really a part of this team, right? We may take care of these patients with horribly infectious diseases and they leave. And then the poor housekeeper is left with what do I do? All of those people were dressed with all of these things. And now I'm left in this room. Right? Can something infect me? Is it going to go home to my family? Is it going to go to the dormitory where I sleep? So involving all of those people, in that perspective, is very, very important. I've had many times in my career, just because of the familiarity with the housekeeper. Again, you've got this power struggle, right? Can the housekeeper talk to the nurse or talk to the boss, right? What is that? But you really kind of brought those folks into the team when they come and tell you, hey, Mr. Steve, that patient in that room is standing up. That's important, right? That's important because it's now given my attention to go to a room to prevent a patient fall. And that I was alerted to that by the housekeeper. Even better, I've walked by rooms hearing housekeepers tell patients that it's important for them to stay in bed and they'll go get the nurse for them. That's a person that's on routine.
Your examples are terrific, really emphasizing that healthcare is really a team activity. We often focus on the physician, but it's not even just the nurse, in addition to the physician, the housekeeper, the phlebotomist,
Absolutely.
if that is in that system. It is the support staff are more globally, right? All working together creates the best opportunity for outcomes. So let's pivot. So ton of great content there on Joint Commission International and your experiences there. I know you spent some time afterwards at Vocera focusing on the voice
Right.
of the patient and really the patient's experience of care, because it's stressful being a patient. It be unnerving, right? Because you're often a patient when you're sick, and so you're already potentially not
Absolutely.
feeling good. And then there's the financial implications of being sick sometimes, unfortunately, and what it means for one's family and all these things. So already a stressful time.
Right.
Interacting with the healthcare system can sometimes, unfortunately, be more stressful. Help me understand some of your learnings from your voice of the patient work and how that might apply to patient experience of care in an international setting where hospitality is often more of a priority than it may be in the United States.
Again, I think those are all really super important things. I mean, we all have. It's kind of back to that brand standard. I knew I'm kind of reverting back to that, but when having an organization that is focused on me as a patient, right? What do I like to eat? No, short of a few diagnoses, people typically don't like to be in a hospital, right? So there's stresses that come from simple hospitalization, even if that's outpatient. For me, it's a lack of control. Right? As a nurse, I have this super critical view, but to me, it's a control issue where suddenly I'm no longer in control. So I think having those perspectives, right? Caregiver communication, involving the patient in that communication. As a bedside nurse, I used to ask patients, when, when do you take a bath? When do you take a shower at home? Oh, I take a shower at night before I go to bed. Okay, let's put that into the care plan, right? Rather than forcing you to get up and take a shower in the morning, right? Let's keep your routine. Back in my bedside days as an ICU nurse, I probably broke back then more visiting rules, which were much more strict back then. I would bring the family behind the curtain, right? I would have a spouse help me bathe their spouse, right? I was the foreigner. Right? I had met that spouse maybe 1 hour ago. The other spouse has been with that person, their entire married and dating life before that. So really having that perspective, as you come together in organizations that are really focused on this. This is one of the important things that we bring from a Medpoint Health Partners perspective is we really help an organization look at all of these aspects. We're working with a client now who's looking at a project in the Middle East, and much of our conversation is about what's this patient experience going to be like. How is this room going to be designed, right? If you've got a room where you've got to go in and start spinning the patient around in order to get their head properly on the MRI, that's wasted time. But it also disorients a patient, right? We can be disoriented turning around, standing upright. Imagine laying flat on a bed and being on a gurney and being spun around, right? But now we've got a patient who may feel ill, and so those are really simple kind of ergonomic things, but they really play an important part into that patient experience. Colors of a room. There's all kinds of science right behind colors and music, and really starting to incorporate that stuff in. And you see these global organizations who are really focused on that, especially the brand new organization, have the opportunity to do it right from the beginning. And that's really an exciting thing when you look at global healthcare.
as you talk about colors and that experience of being a patient, the stress, I think one of the places that gets it relatively more right in the United States is pediatric, compared to adult
Absolutely.
medicine. Like if you go into a children's hospital, the walls will have more color. You have a child life therapist, there's music. They're not waking up, if anyone has children, they're not waking up kids in the middle of the night for
Right.
unnecessary every 8-hour blood draws. They're deciding,
Right.
team, do we even need to draw blood on this kid? They allow the family and the parents, if there's a parent involved, to be there with the child because they understand that there's ways to alleviate stress, what is already a stressful
Absolutely.
situation. I think adult medicine has a lot to learn from. That's what it brings that to mind as you give those examples. Um,
Right. Even something back to pediatric, even uniforms, right? When you look at pediatric, taking off that white coat, um, fun smocks, right? And really trying to get into that. Amazing. Back in my joint commission, I was doing a survey in Managua, Nicaragua. Had one of the funnest pediatric units I've ever been in my life. It was all like you were in a submarine. So all the rooms, all the doors in the rooms had portholes, but the portholes were low on the door so that the kids, when they were in the room, they could look out the porthole. And when they looked out the porthole, when you got down to the level of the children's, when they looked out the porthole, the walls had been painted like it looked like it had waves and fitted. So it was very weird when I was walking. I'm quite a tall person. When I was walking, the painting of the ward seemed very disproportional. And I had a very smart nurse tell me, "Well, you're not a child." So get to the level of the child, and everything was in proportion. And it was honestly one of the coolest things I'd ever seen. So that set a whole stage of now I certainly looked at the standards and I evaluated them critically. But again, it immediately checked the box that this organization knows their patient. This organization knows how to make themselves safer. And this organization knows how to take an extraordinarily scary time and make it as fun as it can be for kids and the parents alike.
that's a great example of the lower windows that the kids can
Mm.
peer through. Um, so as you've traveled, right, and you've seen a number of high performing international organizations, JCI accredited, other international organizations that you've seen over the years, how do you characterize their focus on hospitality? Are there some common themes you've seen there, especially organizations that serve patients, let's say, from multiple parts of the world?
Right.
How do they how do they make those patients feel more comfortable, right? More at home, more engaged with in culturally appropriate ways?
Sure. I think that's really kind of multifaceted. It can come through something as simple as food, right? When you are in a Muslim country, ensuring there's halal food, right? You don't want to give a patient this added distress of having to consume a meal that's not been prepared culturally or religiously in what is something that they believe in. Culturally appropriate care. When you look at, there are still parts of the world where we have gender separation, right? We're kind of out of that gender separation, but when I was first in Earth, we had very strict gender separation. So you do see this gradient, and it's ensuring that it's prepared, that you have the opportunity. If I was taking care of a female patient in the United Arab Emirates, I would know to ask, I'm your nurse today. May I take care of you? Because that's going to involve touching you. And I had patients that would say, no, this is not you. It's not that I believe in the lack of skills, but as a Muslim woman, it's my belief that this is not a part of care I want to engage in. So the organization, as the chief nurse at that organization, I had to be prepared with a mixture of staff. I had to be prepared with clinically competent staff that could interchange themselves, seamlessly interchange themselves, not the patient make like they're the burden, right? The patient wasn't the burden, it was the obligation of me as the organization. Having appropriate places, you do see international hospitals where you see, a lot of patients in a ward, but you also see organizations that have really thought through, the family dynamic in in Asia, specifically Southeast Asia, where a family member stays with the patient, right? You've got to have room for that. Otherwise, you suddenly don't have room, right? So, where you want to be sensible in building, right? There is an understanding of the metrics and the square footage and how that's all reimbursed, but understanding that if nobody's in the bed, nobody's in the airplane seat, then all of your ideas of square meters and square foot and reimbursement are gone because there's nobody in your airplane seat, right? There's nobody in your hospital bed because they have the location that has a better understanding of that. So those are a couple of examples. I think one of the first things that I did, that I educated myself when I first went to the Middle East, was I had to know more about the culture, and I certainly had to know more about the religion to understand what are the social norms that's related to this. And I think that's an important thing when we look at global healthcare. How does an organization address that?
I think those are terrific examples. Stephen, I want to be mindful of your time and
Sure.
very, very grateful for your expertise. I want to be cared for in a hospital where you have been the chief nursing officer, or otherwise exerted some authority with regard to competency, team building, empowerment of the right staff in the right way to ultimately support patients. It's really clear you have deep experience across your many years here, and I think anyone is lucky to have you. And we're lucky to have you on this recording today.
Thank you. In reverse though, Kumar, I want to add a few more things. So this is where I think world-class health it's really closing a really needed gap, right? For years we've snuck to Canada to get cheaper medicine, not bad medicine, cheaper medicine. We've snuck to Mexico for cheaper medicine and cheaper healthcare. So I think this opportunity, the more I know about and learn about what world-class health is doing, it's going to help close this gap, right? I think you're going to be a super important piece in a complex decision making to show organizations that there are other settings. It is a place where you're safe. It is a place that we, meaning world-class health, has assessed. This is an organization that you can trust. This is an organization that meets standards. And I think the more we can bridge that gap and narrow that gap, just helps everyone, right? We both know, as both of us, many, many years in healthcare, it comes down to something very simple, and that's access. We can have the world's smartest people, but if you can't access them, then the patient can't take benefit of that. So any opportunity we can take to improve access, both home in the U.S. and abroad, I think are just safer and better for everybody.
Stephen, we're 100% in agreement on that. Just this morning, there was an article in the Wall Street Journal about how difficult it is to get access to great cancer care. Financial costs are a big part of the challenge. And I'm sure you read it.
I read it like 30 minutes before our conversation.
Yes. Unfortunately, we're seeing that in so many parts of healthcare. And,
Right.
There are global opportunities to get great healthcare. It has, until recently, people haven't necessarily thought about it in terms of a global market like we do for many other things, like manufacturing, call centers,
Absolutely.
and many other things. And your perspectives are very valuable because you've really been in the trenches. You've spent decades serving patients abroad and helping people understand that there really are great options. There may be options that are better than many parts of the U.S., but there are standards that people can feel really good about that came from the U.S. Joint Commission, reduce variances, ensure team building, ensure high quality. And I think if more and more people come to that understanding and there's a willingness to look at healthcare globally, I think it's a great opportunity to improve access, to reduce costs, and actually, in many cases, create as good or better patient experience of care. And your thoughts are very valuable, I think, to our audience to help them understand really what's out there If you haven't traveled abroad, it's hard to know that, but truly it's a global world where there's great global options. So
Absolutely.
thanks, Stephen.
You're certainly welcome.
Look forward to being in touch and have a wonderful day.
Great. Thanks so much.